Good afternoon, everyone, and welcome officially to Health Journalism 2026. We're very glad that you're here in Minneapolis with us. When HCJ first selected Minneapolis for this conference, it was partly because this organization has deep roots here. HCJ was founded nearly 30 years ago in Minnesota and was originally affiliated with the University of Minnesota. So long before this became a consequential moment for the state and for the country, bringing the conference here already felt meaningful. But this gathering now arrives at a particularly complicated moment. Over the past year, Minnesota has found itself at the center of some of the country's most urgent and painful conversations about political violence, public trust, immigration enforcement, public health, grief, accountability, and the limits of our institutions. And for many people here, those events are not abstract political debates. They are lived experiences that affect whether people feel safe seeking care, trusting their institutions, participating in civic life, or simply moving through their daily routines. And at the same time, many of the systems we cover as journalists are themselves under extraordinary strain. Scientific expertise is increasingly politicized, public health infrastructure has been weakened, access to information is becoming harder, not easier. And the people we report on and report for, patients, providers, researchers, immigrants, caregivers, families, are often carrying enormous uncertainty about what comes next. In the midst of that are journalists, trying to separate signal from noise, trying to verify facts in an information environment built for speed, outrage, and division, trying to report rigorously while also remaining human. I think it's important to say clearly that sustainability matters, not just for our newsrooms, but for us as people, because many journalists, many of you, are exhausted. People are navigating layoffs, shrinking resources, harassment, online abuse, financial instability, and the emotional toll of repeatedly covering trauma, conflict, illness, and grief. So while this conference is absolutely about sharpening our reporting and our skills and asking hard questions, it's also about something else: how we sustain one another, how we build community in a profession that can often feel isolating, and how we continue doing rigorous, compassionate, evidence-based journalism without losing ourselves in the process. I hope that's what HCJ can offer you: a space for difficult conversations, space for learning, and a space to reconnect with the people who understand this work most deeply. Over the next few days, we'll continue to talk about immigration enforcement, misinformation, political violence, threats to scientific research, public health instability, health inequities, and the future of healthcare itself. But we'll also talk about collaboration, mentorship, resilience, and what it means to continue showing up for this work and for one another. We're honored to have you all here. And before we continue, I have a special video welcome from Minnesota Governor Tim Walz.
Hello, everybody. Governor Tim Walz here. At the moment of escalating attacks on public health and journalism, I'm glad you are in Minnesota coordinating for the difficult work ahead. Truth matters more than ever. Science matters more than ever. We have worked tirelessly to bring forward health initiatives that benefit all Minnesotans. I'm extremely proud of what we've accomplished. We've established a fundamental right to reproductive health care, including abortion. We've invested in adolescent mental health and school-based health dinners. We banned the cruel and discredited practice of so-called conversion therapy. While there's more to be done, I hope that we can use Minnesota as an example across the nation. And this message goes out to our journalists, healthcare professionals, policymakers, and industry experts across the country. Minnesota will stand up for you, and you are welcome here.
And now I'd like to introduce the president of the HCJ Board of Directors, Gideon Gill.
Tough act to follow Coach Walz. Welcome to HJ26. Health journalism has never been more important than it is now. In this time of rampant misinformation and hyperpartisanship, the public counts on us to deliver news accurately, clearly, and impartially. Journalists have never been as beleaguered as we are now, as Kelsey already spoke about. We're facing repeated rounds of layoffs and intimidation through unfounded lawsuits and threats from the FCC and the FBI even searching and seizing electronic devices from a Washington Post reporter's home. Government officials have always controlled access to information, but under this administration, it's worse than I can remember. Catherine Reed, who tirelessly orchestrates the programming for this conference, spent many hours reaching out to administration health officials, inviting them to speak this year, but she was either turned down or ignored. Marty McCary accepted after his resignation as FDA commissioner, then pulled out less than 24 hours later. What we do can be grueling, and yet we persevere because, as Hannah Nathanson, the Post reporter whose home was searched, told graduating students at Columbia Journalism School recently, quote, "Journalism is not only the foundation of our democracy, it's the most fulfilling work you'll ever do, and the most fun you will ever have." So keep that in mind. Now on to this afternoon's program. More than 15 years after enactment of the Affordable Care Act, we are not simply debating how to get universal health care. We are also debating whether it makes sense to try. For this session, we'll get two perspectives on those questions, one from the left, one from the right. In a look back at the upsides and downsides of recent policymaking. Then we'll focus on today's debates and the very different choices of on the political agenda. Moderating this session is Jonathan Cohn, a senior national correspondent at the Bulwark. Jonathan covers politics and policy with a particular focus on social welfare and healthcare. A former writer and editor at HuffPost, The New Republic, and The American Prospect, he has also written for the New York Times, The Atlantic, and Self, among others. He's a two-time winner of the Sidney Hillman Prize for Journalism and was called one of the nation's leading experts on health policy by the Washington Post. He's also a huge baseball fan, by the way, so you should talk to him about that. John, you want to come up?
Just to clarify, I'm a big fan of the Boston Red Sox, so if you want to discuss that, happy to, although maybe not so much this year. Gil, thank you, and I should mention I'm a big fan of Stat News, which I was telling Gil earlier, if you're not reading Stat News, you're doing it wrong. It's just one of the best publications out there, so honored to be introduced by you. I am excited to be here. I am excited to be debating and discussing this topic with these two people sitting next to me. I'm going to tell you more about who they are in a moment. But first, this has been an extraordinary year and a half of change in health policy ever since President Donald Trump took office and has worked with the Republican majority in Congress to enact a number of major shifts. The most important among them is the legislation that passed last year, known as the One Big Beautiful Bill, that included the largest ever reductions in projected spending on Medicaid, which, as I think most of you know, is the almost $1 trillion a year federal state program on which nearly 70 million low-income Americans rely for health care and has become a pillar of financing for hospitals, clinics, and all kinds of providers. And it's not just Medicaid that's been affected. There have been changes to the Affordable Care Act, the financial assistance available to people buying coverage through healthcare.gov or its state counterparts like Covered California. Now, the people who support these actions, who have cheered them, they say that this is necessary to return programs like Medicaid to their original purpose, which was to serve the neediest Americans, the people who are really, truly most vulnerable. And they look at expanded Medicaid or expanded ACA, and they see a program that has become full of waste and abuse, fraudulent enrollment, and that is putting a drain on the federal treasury at a time when we have serious debt problems in this country. Opponents, they disagree with all of that, and they see a set of changes that are going to deprive millions of health care and reverse historic progress towards universal coverage at a time when the percentage of Americans without insurance had reached a record low. Now that debate should sound familiar because it's been around for a while. I said it's been an extraordinary year and a half. It's really been an extraordinary decade and a half, going back to roughly 2010 when it was President Barack Obama and the Democrats in Congress who were in charge, and they passed the Affordable Care Act, the single largest expansion of the American welfare state since the 1960s. Now ACA, you probably know it as Obamacare famously, changed the rules for how insurance companies can operate. It set up the marketplaces, healthcare.gov, covered California, and then put what was projected at the time to be almost $1 trillion over 10 years into either helping people buy private insurance or to get expanded Medicaid. Basically, the things that Trump and the Republican Congress have been partially trying to undo are the things that Obama and the Democrats did. That's an easy way to think about it. And the arguments then mirror the ones now. Proponents said the Affordable Care Act was a way to help all Americans, but especially those struggling to get health insurance. Critics saw a bloated program, one full of skewed incentive, prone to waste, that was going to actually make health care worse, not better, for the majority of Americans. There is a straight line from the arguments in 2010 to the arguments we are having now, but precisely because they're always in the news, it can be hard to know what the argument's really about. What do the two sides really believe? What are they really trying to do? Where do they really disagree? And by the way, where do they really agree? Because there is some overlap, and I could not think of two better people to discuss these than the people next to me. So on your left, over here is Jeanne Lambrew. She is a senior fellow at the Century Foundation. Her career in health policy officially dates to 1993 when she was a newly minted PhD from the University of North Carolina. Go Tar Heels. Any Tar Heel fans out here? Usually? There we go. From the University of North Carolina, went right to the Clinton administration just in time to see their effort at comprehensive health care reform fail. But she stuck with it, worked on healthcare, out of government, in government, was part of the Clinton administration. I have often said there is no single person who wrote or implemented the Affordable Care Act, and that is certainly true, but there is a small group of people who were chiefly responsible for its construction and implementation over the year, 24, maybe a little more. Jeanne, who reportedly does not sleep, was one of them, especially if you take into account the time she spent as Commissioner of Health and Human Services in the state of Maine after leaving the federal government. On your right, yes, is Chris Pope, Senior Fellow from the Manhattan Institute. He was educated at the London School of Economics. Do they have a basketball team? They do not have a basketball team. Be fun to come up with a name for them. He was educated at the London School of Economics and Washington University in St. Louis. He also has had a front seat to healthcare reform. He was a fellow serving on the staff of the Energy and Commerce Committee of the House in 2013 and 2014. ENC, as it's called, is one of the committees in the House that has direct jurisdiction over healthcare. So he got to see the rollout of the Affordable Care Act at a time when it was not at its best, let's just say. And he also, since then, is a prolific writer. You have probably should have seen his bylines in Politico, Wall Street Journal, Health Affairs. You'll notice that's for a general audience and an academic audience. This is someone who can talk to normies and he can talk to wonks. Speaking of writing, he's the author of a new book that is coming out called The American Way of Welfare. He did not want me to mention that. I think he thought I would embarrass him and tell you all to go out and buy it. I'm going to embarrass him and tell you all to go out and buy his book. I got a chance to glance at it. It is really interesting, it is smart, and it is thoughtful. And that is the kind of discussion we are going to have here today. You know, there's a reason Jeanne is on your left, Chris is on your right. They do correspond roughly to sort of the left and right views in American healthcare debates. And I want to be clear, they are not partisans, they're not speaking for a candidate, they're not speaking for a party, and what they say will not always line up with talking points, and again, you may find they agree on some things. I'm genuinely curious to tease that out. But they will give you a sense of the two different worldviews at play here, and it's really important to do that because these decisions, they affect you, they affect what you cover. You're the eyes and ears of America, and it's important to know where this is all coming from. So we're going to start with a really big question, and they've been prepared because I told them this is where we were going to start. Because it's not a debate, we're not scoring points, we're not trying to declare a winner. But my opening question, we're going to go at the most abstract level possible. Well, not most, but an abstract level, which is this. Do you believe the United States government should be in the business of guaranteeing health care for every legal resident? I'm going to start with Jeanne and take a couple minutes and give us your thoughts.
Great, and I will just begin by saying thank you all for being here. Thank you, Jonathan, for your excellent reporting, documentation, and historical analysis of many of these issues, because I learn from his writing, I learn from your writing, so thank you all for your work. So I'll just begin by saying, what does government do today? Answer the question going backwards. We know that every aspect of healthcare almost universally is touched by government through regulation or some other mechanism. We know that 40% of all national health spending, or $2.4 trillion this year, will be spent by the government on healthcare. To put that into context, the amount that is spent on Social Security is $1.4 trillion. The amount spent on the Department of Defense is $1 trillion. So already government has a major role in our healthcare system. And a recent survey by Pew Charitable Trust found that 66% of people say that the federal government has a responsibility to make sure all Americans have health coverage. That includes 41% of Republicans, which is a minority, but that 41% is up from 30% just 5 years ago. So what do people want? They want government, but I think it's also important to recognize what they don't want, because I do think we're in a time when we all, and you all know this, we hear about people frustrated getting insurance, frustrated navigating insurance, struggling to get care that their providers prescribe for them, and then struggling to pay for it. And who do they blame? Private sector, the private insurance industry, the drug companies, many of the private providers out there. And there's some good reasons for it. I can just name 3 examples of what people call corporate greed. One is that most recently, U.S. News and World Report came out with the top paying jobs, and using their definition, median income. 9 of the top 10 best jobs in this country are healthcare professions. Another factoid is that some authors in JAMA Internal Medicine look back from 2001 through 2022 to look at corporate shareholder-driven medicine, and found that not only did the number of health companies in the S&P 500 double in that period, but their payback to their shareholders tripled. And to put that into context, $170 billion was paid out of the healthcare system to shareholders in 2022. And a third example of why people are frustrated, and in some cases, a colleague called it pitchfork angry at the system, is because even our nonprofits are sometimes acting like for-profit organizations. And I'm going to paraphrase the Indiana Secretary of Health, who I saw speak at a conference last week. They just passed a law last year that said if a nonprofit hospital charges more than 2.5 times of Medicare, a little bit more than that, they're acting like a private for-profit hospital and should be treated as such and will lose their nonprofit status. That's the kind of sentiment that's out there. So even though in the past people have been skeptical of government, I can show my scars about people not liking what government does to their healthcare, they may be at this point in time even more frustrated with the private sector. So I'll go back to the question, do you think that government has a role in ensuring people have coverage in this country? My answer is yes.
Chris, over to you.
I think we have a very frequent, two-track discussion with healthcare. We have a discussion in the public, which is often, should people have healthcare or not? Should we have universal healthcare or not? And then we have a discussion among experts, which is how much and who pays for it. And it seems to me that that former discussion gets in the way of the latter. We have certainly a concept in law that's the concept of medically necessary care. That's what insurers are required to provide. That's what our entitlement programs are required to provide. That conforms to the binary view of healthcare, the view that it's all or nothing. But what that actually yields in practice is it yields a commitment to pay for any healthcare where the marginal benefit is greater than 0, regardless of what the marginal cost might be. And I think quite often throughout our healthcare system, this is a fundamentally unhelpful attitude. It underlies why we are so insensitive to cost in many areas. It underlies why we're pretty indiscriminate in what we're subsidizing. I think we also have this sky's falling attitude to what we're doing in healthcare. And we do a lot of things that are really good in healthcare. If you go back to 70 years ago, before modern insurance, modern entitlements dominating the industry, and you say, would you rather have the healthcare system from then or the healthcare system from now? We're obviously getting an enormous amount of value. We do some things that I think in principle are very, very good. We have the principle that people are expected to provide for themselves if they can. We do this through employer-sponsored insurance, which has some flaws I'm happy to talk about in a little bit. But I think as a way of covering working Americans, as a way of nudging them into coverage, in a way of making sure that the finances are there and that there is no moral hazard, people don't kind of opt out of coverage until they get sick and then need it. That's actually a fairly sound way of doing it in principle. I think having entitlements to fill in the gaps for the elderly who are no longer have employers, that makes sense. Having means-tested programs, basically for people who can't afford it, targeted subsidies, that also makes sense. But these are incremental decisions. And they're also, in spirit, they're not all or nothing. And I think that's a really helpful mindset, that when we start to have discussions about universality, I'm always reminded of my time on the Hill where every interest group comes up to you and they say, this has a positive health impact. And there is just this expectation that public spending will be provided indiscriminately. If a hospital can say a certain expenditure improves health, that's medically necessary. Who can argue with that? And we fall into this runaway train of spending because we've set the threshold ultimately, implicitly, fairly low and far too low, or not necessarily there should be a single uniform threshold, but we've locked ourselves out of what should be an incrementalist discussion, a discussion that recognizes that there's variation in effectiveness of medical therapies, a discussion that recognizes that there's variation in ability to pay. Some people are able to pay for themselves, and a market-oriented environment works well for them. Other people are necessarily dependent on public payers. But the issue of to what extent never goes away. And I think that's the essence of so much of healthcare policy and good healthcare policy making, is the to what extent question. And that's what makes me frustrated with the idea of universality, which sort of implies that we could give everything to everybody, which we obviously can't.
I see you nodding, so I'm going to...
Yeah, so I will just say I do think there's something different about the debate this year, which I do think the concept of universality is more widely shared than it ever was. But again, going back to yes, no, should people be covered versus what that coverage mean, I think is where our debate is. And I will agree also that there is so much good in the healthcare system, which is why people want it, and why honestly I think people think of it more as a public good than a commodity. We're to a point where many people will think that it should be there for, and I think medical necessity is not what most people think. I think they think of emergencies. I think they think of getting access to a primary care provider when their child is sick or they need care, or not facing extraordinary bills or hassle when they try to get that care. That's not necessarily medical necessity. That is a system that may not be delivering on its promises.
I think one of the most challenging things with healthcare policy is the really expensive stuff is the medically necessary stuff, right? So if you think about the $200,000 cancer drug, that's obviously medically necessary, which means that we have this really awkward conversation we don't actually have at all. If you think about the really expensive hospital admission, we're talking about hundreds of thousands of dollars quite frequently for a major cardiac event. I think a lot of our discussions of health policy frequently are assuming that there's a core of useful stuff and then there's sort of the froth that's surrounding it. And we can easily kind of reduce down to the core and let the froth go. But often it's not that neat. And what we have is and I'm certainly of the belief that one of the biggest challenges we face embedded through our healthcare system is what I think people have called the medical arms race. The idea that there are more, because we have this open-ended commitment to reimburse for any technology that's developed regardless of its effectiveness. It encourages the proliferation of new drugs, new surgical procedures with somewhat marginal effectiveness. And we end up with a vast array of things which technically are medically necessary, but are really on the scale, on a very, on a scale that is not a dichotomy, on a very gradual slope from the $200,000 cancer drug that extends life by maybe a month or two occasionally, to the antibiotic, which costs $5, which is probably the most useful part of the whole healthcare system. And so there are these, what we would like the ethical trade-offs to be in healthcare aren't actually what the practical economic trade-offs are. And we kind of box ourselves in with our philosophy sometimes. So
I want to stay on this one more second, and I do want to get to like the current debates in the United States, but I wanted to say, and this picks up partly on what you were just saying now. Obviously, if you look around the world, let's look at the EU countries and Britain, et cetera. They all make those decisions. They do, and they have universality, and their systems, they get universal coverage. They spend less than we do. You obviously don't want to see, I'm assuming, reading and tell me if I'm misreading what you're saying, but you do not want to see us move to one of those systems. So why not? I mean, a lot of people look at that and say, it seems pretty attractive.
Right. So, I mean, I think there are several dimensions to this. I think an important one is, I think the European countries limit the whole healthcare system to public revenue. Britain, for instance, where I grew up, was the amount of public financing for Britain's healthcare system is about the same as a share of GDP as our amount of public healthcare financing. It's about like 9% of GDP. It's about what we spend on Medicare, and Medicaid is what they spend on NHS. But instead of essentially spending that amount of money on filling in the gaps of what private resources can provide, it entirely displaces private resources in Britain. And so there's just less money to go around. And so the rationing decisions that countries make when they're much more dependent on, or they're exclusively dependent on public funds, are much more acute than they would be if you have a multiplicity of payers and when you're able to bring in additional private revenues to finance an extension of the healthcare system. I think this is fundamentally a very good thing that we do. Now, we make many other errors in the process, which I'm happy to talk about. I think employer-sponsored insurance is very insensitive to cost in a very harmful way. A lot of our entitlement programs are pretty clunky and not very sensitive to value. But I think in principle, that element of a healthcare system is very important, the ability to have both private resources and public resources, rather than just having public resources crowd out private resources for everybody.
And I just would respond by saying it's not like we don't have rationing in this country. We do. We have behind the scenes private rationing that happens even with government funding by actors who are trying to meet their margins, maintain coverage with the premium. So we get rationing by high deductibles for people who can't navigate them, rationing for people who can't make their way through the maze of eligibility rules for programs, rationing by people who can't navigate during their day job or with their large family stress the process of getting through to somebody for a prior authorization, to doing internal appeals, to doing external appeals. So I think we have rationing, but in a much more inequitable way in this country because we don't take it on. I think rationing is almost inevitable in any world in which, as you said, there's some value above which society may not be willing to pay. There may be an interest in demand for that. And I don't say we shouldn't have that demand, but shouldn't we have those discussions as a country publicly rather than letting private actors make those decisions?
I'd say that a real important distinction is that when you're being denied, say, prior authorization, or when cost sharing makes access to a certain kind of care difficult or impossible, that's very visible. You notice what you're being denied access to. If you're in a country that has rationing by National Institute of Healthcare Excellence in England, that's silent. You don't even know what you're being deprived of. The drug is out there, but it's not even available. It's happening without you even knowing. And so there is the silent rationing that's actually twofold. One, it's like the things being kept from the patient that the patient doesn't even know is being kept from him. And secondly, it's being kept from the process of research and development because the market is not there, anyone who's developing. And there's a sense in which because businesses developing new drugs, new surgical techniques, new devices know that the American market is out there. The Europeans can kind of piggyback off of that development. The problem would be much more severe if the United States went to, shall we say, keep it short, a single payer model. Because if a procedure was not covered or if a drug was not covered here, it just wouldn't get developed in the first place. And that's a fundamentally different type of arrangement.
I'm going to ask you one really quick file, and then we're going to move to it. But so just to follow up on what Chris was saying there, I mean, yes, there's rationing now. Why are you, government does a lot of things pretty badly. Are you really confident that the government's going to, if we have more government oversight, more government regulation, we'll actually end up with a better set of decisions?
So I think we see today, in states, for example, we have states that set benefit requirements for their insured markets. We have state-based marketplaces, and actually all states do essential health benefits in the Affordable Care Act, make decisions about what is and is not covered through usually public processes. That is a type of rationing, what is included, what's not included. We see that, I think, with different standardized benefits in some of our different states where they standardize cost sharing and make choices about what is zero copay, what is some marginal cost. So we make decisions about coverage a lot, and it's not all or nothing. There's a lot of in between. I would argue that it's never perfect, but I think that the public processes, I was involved in several of them in my different parts of my career, at least they are transparent, they are visible, they cannot moderate over time, and I think, again, it's a better way than it happening to people who are just unfortunate enough to trip into the circumstances where they, as individuals, for their circumstances, could be denied.
I could keep going on this thread forever, but we're going to move to sort of an example of the government getting involved, which was the ACA, in which, as I said, you were so involved.
Yeah.
Give me, now it's been 16 years. 16 years. Give me your high 30,000-foot assessment here of what went right, what was good, what was bad, successes, failures, pros, cons, strengths, weaknesses.
We don't have enough time to do that today, but I will do the very quick, very short version, which is really going back to the 2000s. There were two great problems of the time. One was that we had nearly 1 in 5 people in this country who were uninsured. And putting aside people who are underinsured, which is terrible, the research is pretty conclusive that when you have no insurance, your risk of premature morbidity, mortality, life problems, stress is much greater. So it was a severe problem, as was the relentless rise of healthcare costs that was growing rapidly as a percent of our national economy. So by the time the Affordable Care Act got across the finish line, it was not exactly what we all would have liked. It was further eroded from the day it began, from repeals, Supreme Court actions, state actions, rule rollbacks, et cetera, and then the Trump administration made some significant changes. All that said, we actually met our 2 fundamental challenges. We did reach a record high number of people with coverage in this country, 92%. Actually, just yesterday, the National Center for Health Statistics released its version of a survey that documents how many people have coverage in this country. Again, 92%. Sherry Gleed at NYU has written about how that actually is close to what Canada has when you begin to take into account immigrants and other exceptions to coverage. So we did do something important in terms of proving that government could come close to universal coverage in this country. And on the cost front, for those initial years, we did stop that growth of national health spending as a percent of our economy. It's stabilized for a good decade. That has changed, but not only was the law imperfect at its passage, but it certainly did change. No single law, I would argue as well, has a shelf life of 16 years. I mean, things change, loopholes erode. We were talking yesterday about prior authorization was not really a thing in 2008, 2009. We couldn't anticipate what came next. And in fairness, I think when there's organizations out there, again, trying to meet shareholders' needs, they'll find the loopholes, they'll exploit the loopholes, and if government's not quick enough to catch up to them, they will persist. So did it achieve its major goals? Yes, for a while. Could it have been better? Absolutely. Do we need to do more now? Yes. And do we need fundamental reform? I'd argue yes.
So you probably know this better than I do, but I think the Affordable Care Act was 900 pages long or something roughly.
I don't remember the number of pages.
But anyway, so I would say out of that, probably,
Depending on what font size you
right.
use.
It was actually shorter than the rule for the 2027 marketplaces that was proposed last month.
So my point is that out of the 900 pages, I would say the political controversy was probably on about 100 of them.
Yeah.
Like the vast bulk of the bill, even though it was super long, was fairly uncontroversial. It was just like this massive bill that a lot of it, which would have got bipartisan support. I think you have three big areas in the bill that were very controversial. The first three titles, I think, were the big, meaty titles that all the fighting was about. So the second title, I think, in dollar terms, was the largest. This was the Medicaid expansion. I think in the initial plan for the legislation, that wasn't actually supposed to be the biggest title in dollar terms. I might be wrong about that. But I think that is, if you actually think about the ACA's legacy in terms of coverage reduction, it's overwhelmingly the Medicaid expansion. I think initially, if you followed the public debate about the ACA, it was the insurance market reform that was going to be the biggest part of the bill. So I think what's controversial about the Medicaid expansion is obviously for the first time we're creating a major health entitlement for able-bodied adults. And for people who could work, potentially could earn money for health insurance or get employment that would get them health insurance. And what the ACA's Medicaid expansion did is it said if you earned less than roughly $16,000, $17,000 as an individual, about 30-something thousand, depending on your larger household size, you would get fully federally financed or publicly financed health care. And so that had the massive, or there were a lot of people, especially in the business community, a lot of Republicans whose major concerns with that were to do with the work disincentives it created. If you're getting this benefit, which is worth tens of thousands of dollars potentially, if you earn less than $16,000, $17,000, that is certainly a serious issue in a way that no health benefit had been before. So I think this is where this concern for work requirements comes from. I think that's really where a lot of the unease about Title II, the Medicaid title of the ACA, comes from. I think the second part of that is hugely controversial is the 9-to-1 match for states. The fact that for any spending that goes on these able-bodied adults, a state can get $9 in federal spending in return for $1 that it puts in without any upper limit. That creates an enormous incentive for fiscal shenanigans that states have never had before that is really unlimited. It gives them an incentive to really reclassify any other kind of expenditure as loosely associated with the Medicaid program. It gives them an incentive to basically allocate all their marginal dollars to the Medicaid expansion relative to anything else, and to employ provider taxes, state-directed payments associate, all these features with this element of the program, which I think its growth has really been completely uncontrolled and very poorly focused on the unmet need. I think it's the majority of the Medicaid expansion has actually just gone to eliminating or displacing private insurance coverage that existed, rather than precisely filling in the gap that existed, the uninsured. And so the crowd out rate has been quite substantial. I think that is a problem with the Medicaid expansion that's never really been addressed. I think, well, politics tends to perceive it iteratively, so I'm not saying that there would have been a big bipartisan kumbaya about it, but in terms of what's vulnerable about the Medicaid expansion, I think that those are the issues. It certainly did some good, but I think those are the issues in it that are most flawed.
So let's stick on the Medicaid expansion. Jeanne, what about this idea that a big chunk, I don't know if you said majority of the Medicaid expansion, was it majority?
Yeah,
displaced private insurance and crowded it out?
Yeah, I'll do my general review of the literature and then to my own experience, having implemented the expansion of Medicaid in Maine. If there had been crowd out of private insurance from the Medicaid expansion, the uninsured rate for low-income people would not have gone down. It did go down. If there had been crowd out of private insurance by the Medicaid expansion, the number of people with private insurance, employer-based insurance, or individual market insurance would have gone down. It didn't. We've seen uncompensated care significantly reduced. There's plenty of studies out there talking about how hospitals and clinics have benefited from the Medicaid expansion. So I think the evidence base is fairly overwhelming that it did indeed cover uninsured people. I will fast forward to my experience implementing this beginning in 2019 in Maine. Number one, there's no state that I know who is not extremely careful about their accounting, because they know the consequences of not accounting for categories in the right way, which is federal sanctions, and no state can afford that. So we were very cautious about how we categorize people as expansion populations versus not. What we discovered were there are many low-income people who had some degree of disability, but not so severe that they qualify for Medicaid under the disability categories. Anybody who has ever tried or helped somebody apply for Medicaid coverage under SSI or disability category, there's medical exams, there's extensive processes involved. It is not easy. So a lot of people give up and remain uninsured. They would get mild enough disability that they were not getting Medicaid. But we looked at that group because we discovered them in the expansion. Could they have worked? They often worked a little bit part-time. But you're not actually really, in this kind of income threshold, getting people who have job-based coverage through their job eligible for this program. So my experience has been it was not crowding out people. It was helping people that otherwise wouldn't be. States feel very accountable to ensure program integrity, and I think my experience was different. I will just go back and say, though, when we were beginning the process of drafting the Affordable Care Act, we had people like Gail Walensky and Stuart Butler, conservatives, who agreed that we needed a safety net floor for low-income people, people with disabilities, in a public program because private insurance wouldn't serve their needs. I think that is still true today. We can debate where that line is drawn, but I don't think we can debate whether it should be drawn.
I want to give you a chance to respond to that. If I can steer the question a little bit, just because I'm looking at the clock and I want to make sure we have time for, which is obviously that thinking was part of what went into HR1 and some of the changes to Medicaid, including the work requirements. So maybe respond in process, but also make the case for the imposition of work requirements on the sort of expansion or the the Medicaid changes in general.
I actually don't like a statutory work requirement as such.
Oh, okay.
So my reason for this is that I feel like if you actually look at the work requirements, the community engagement requirements, they're very easy to satisfy. The state has to certify an individual. Why would a state not certify somebody when it's getting a 9-to-1 match for having that person? I feel like these work requirements are not going to do much effect. What I do think is appropriate for specifically working age population is what we do in SNAP, the food stamp program, which is a time limit. I think what's appropriate for a working age population is to recognize the nature of the cohort is that this is a temporarily needy population that in principle can work, it's not disabled, it's not elderly, and they have an acute need immediately while they're between jobs. But what we don't want to, and what we don't want as policymakers, we don't want this crowd out of private insurance. We don't want Medicaid to be a long-term alternative to private insurance, people falling back on taxpayers. And so what I would like to see for this population, and I think Wisconsin did this through waiver at one point, is basically have a time limit of a few years for an individual who's an able-bodied adult to be able to temporarily access expansion coverage while they are between jobs, but not like beyond there for many years in a row. I think that really is, I do agree. I feel like the pre-ACA status quo, there were clearly gaps in the safety net that needed addressing. But I think the way that the ACA expansion was done was too open-ended, and that tightening it up a bit, it would have been the appropriate thing to do.
So let me just follow up on this time limits idea, because one issue that comes up, as you know, with the low-income population is that a lot of these jobs just don't provide health insurance. So I can imagine somebody who's working as a waiter or waitress for some extended period of time and would not have health insurance. So what happens to that person then?
Well, someone who's a waiter would probably not be eligible for Medicaid anyway because they'd be above the income cutoff.
Dishwasher.
But my point is the Medicaid eligibility is an extremely low income cutoff. We're not talking about full-time minimum wage workers. If you're a full-time minimum wage worker, you're earning well above the Medicaid eligibility cutoff. What we're talking about is people who are unemployed for stretches, people who are not working full-time. The low wage worker, I think that's where I think you can realistically have a discussion about ACA subsidies. I think that's the person, that we're talking about 200% of poverty. And there's definitely a discussion to be had on that and like what the appropriate level of that kind of subsidy should be. But the Medicaid eligibility discussion actually is a lower level of income than the sort of worker that you're suggesting.
So, and I want to pick up on something Chris said, because I hear this all the time when I talk to Republican officials, this 9-to-1 match, taking away the incentives for states to be responsible. I mean, it's practically free money, and you've got hospitals to satisfy, and there's no downside to taking the money, or very little downside. I mean, maybe politically there might be, depending on where you are, but there's all these interests aligned, and it removes the incentives for states to be responsible. And it's one of the reasons we see things like some of the fraud, which, may or, however big or small it may be, the system as constructed is too easy on the states. And they are now stewards of, they have an open spigot that they're not going to take control over. What do you think about that?
So, again, it feels like there needs to be the history context before we answer the question, which is, it's not the first different matching rate in Medicaid at all. Over the years, there has been different matching rates that have been used for different reasons. A 90% match for like building technology for a while. In the Children's Health Insurance Program, in the 1997 legislation, there was bipartisan support for plussing up the Medicaid matching rate by 15% to give states the incentive to expand to the higher income people, with the rationale being they may not be that interested in expanding that population because they want their resources to be dedicated to their low income, vulnerable population. So we were following the past pattern of using the financial incentive for action. And just as a reminder, we thought it was going to be a national floor until the Supreme Court said it was an option. So as a reminder, we were going to phase down that. And even in the Obama administration, before the Supreme Court acted, we thought about blending the Medicaid matching rate so it would be kind of the same across similar populations, CHIP, the expansion group, and Medicaid, so long as we had that floor of coverage. But we knew after the Supreme Court acted and said it's an option, states had triggers that if the 90% went away, the coverage went away. And that's just an example of the behavioral incentives that get put into place to make there be action. Is it the ideal way to fund things? I would think of something different. I think there's lots of better matching rates that we could have for Medicaid. But did it work with all but 10 states having taken that incentive? I think the answer is yes.
So very quickly, because I know people have questions, just like short sentences, 2 or 3 things if you were being asked by an aspiring politician, current office holder, somebody who is in a position to change policy, things that you would advise. We'll go Chris first.
So this is probably of all the issues why I think the proposal that could have the most impact is I think our biggest problem that's causing hospital costs especially to run up is the structure of employer-sponsored insurance. It's the fact that when you have an employer providing health insurance to people, to maybe 50, 100 people in a metro area, by necessity they have to have a very broad network. Because those 50 to 100 people live in different neighborhoods. They have a different hospital that they really care about. They have a different specialist, different doctor they really care about. So if you're an employer that's just trying to satisfy everybody, you pretty much have to have every hospital system, every physician group. And so your ability to negotiate with them as an employer and get a good rate from them is very, very poor. We see on the individual market plans actually able to negotiate much more aggressively with providers than group plans are. We often talk about narrow networks as almost synonymous with poor quality networks, but I don't think that's quite right. I think narrow network could be the physician that you really care about, a couple of specialists that you really care about, a couple of hospitals that you care about, and not the ones the other side of the city that are really expensive and that you don't care about. The issue here has obviously been extending the preferential treatment of employer-sponsored tax insurance. In the first Trump administration, there was a provision in law created called the Individual Coverage HRA, which allows employers to put pre-tax funds into an HRA for individuals to buy their own coverage from the individual market. I think when you do that, you potentially empower individuals to shop around for health insurance the way that they shop around for airline tickets, for hotels, to look at the price, to look at the value. And whereas employers are often skittish about making that trade-off, understandably, because different workers have different providers they care about, when it's individuals doing it, they can be much more aggressive about picking a plan that really is cost-sensitive with its networks. And those incentives feed all the way down. They start to feed down to hospitals that are not always thinking, oh, well, most of my customers are well insured. Let's have the most lavish facilities so that we have lots of well-insured patients come. Being in the most price-sensitive networks starts influencing hospital decision-making when they start making expenditures, capital commitments, and that sort of thing.
So I'll do a quick short term. So let's pretend it's the fall and maybe there's a change in Congress. There will still be President Trump for the next 2 years. So I think that realistically, the short-term agenda might be some version of enhanced premium tax credits returning, especially for that group with income just above 400% of poverty. There's a really big cliff that there's a bipartisan acknowledgement of the challenges that those people face, including people who are self-employed, semi-retired, don't have access to job-based insurance. I also think this idea of friction in the system is something that could get support for legislation to sharpen timeframes, standardize these appeals and prior authorization decisions. I think there's a real desire to try to make it easier to navigate health insurance. I do think that as the work requirements, 6-month redeterminations, other cuts, I'll say, to Medicaid kick in next year, there will be some interest in pushing them back some until states can figure out alternative financing means or alternative ways to support critical services. As well as I do think that Medicare Advantage is ripe for legislation. There's lots of money in Medicare Advantage. Everybody knows that. You could take some of that money and make Medicare benefits better across the spectrum. I think that could be something on the agenda. As well as, I'll just say, going back to the discussions about UK and different systems, President Trump introduced this idea of most favored nations, which is effectively reference pricing for prescription drugs. And, I think smart legislation could take that impetus and do something meaningful with it. And I'll just say for the long run, it's hard to look that far ahead, but there really needs to be a rebuilding of trust in government, trying to figure out the simple guarantees in this fragmented, complicated system around what people get, how much they pay, how much we pay as a society. I think that's coming our way, but it's a little early to say what that looks like.
Terrific. Questions? Line there. Joe.
Thank you very much, Jonathan, Chris, Jeanne. Fascinating discussion. Chris, I wanted to ask you about the idea that consumers can shop for health care. The price transparency and insurance transparency rules have been in place since 2000, 2001, and yet a lot of our members have struggled to gather that information for their own readers and for themselves. Some of them do quite well, but it's a giant lift. It's a big project. And the the Purchaser Business Group on Health in California did a huge report that they published in December. It's 81 pages on their efforts and their employers, their large employers. They spend billions of dollars every year on healthcare for their 40-something members. They're some of the largest companies in the world. And they struggled to get health insurers and hospitals to agree to help them to produce this report, and they were stymied at many turns. And so how is it that consumers and even big purchasers are supposed to empower their employees when a big organization like PBGH struggled to do it?
Yeah, I'm pretty skeptical about consumer-facing price transparency. I think ultimately every patient is going to have a very different cost exposure, they're in a different insurance plan. Different insurance plans have different contracted rates with hospitals. Knowing the average rate for all payers is not particularly helpful. Individual patients are going to be in a different place relative to their deductible every year, and so knowing the average fee is not really particularly relevant to them. I think in terms of getting good value for hospital care, I'm much more focused on encouraging narrower networks. The insurers are the ones with the incentive to understand value here, to be able to shop for value. They're the ones negotiating the fee. They're the ones that we can actually hope to reduce costs. I think the sort of broad price transparency databases might be useful for researchers. It's kind of nice to know the distribution of costs out there. But for actual consumers, I don't think anyone's going to be using these prices. They're ultimately not the prices that they specifically are going to be paying.
I'm going to go to the next question. Just to go over here. Go to this side. Thank you.
Hi, thank you both so much for the really interesting and nuanced conversation. I'm an editor who works with primary care physicians. This is obviously a topic that is very hard-hitting. I had a question specifically, Chris, you had a comment earlier when we were talking about the concept of universality. And you kind of commented about how, unfortunately, a lot of times, issues or conditions that are medically necessary are really expensive. You used the example of cancer. But I'd like to push back onto that a little bit and kind of emphasize how many chronic conditions in this country, diabetes, obesity, heart problems, these are all often a result of not getting routine care and addressing it before it becomes a chronic health condition. So universality could help people get more routine care earlier on before it becomes an incredibly expensive condition. And so I worry that those kind of comments sort of justify this snake eating its own tail of ignore the root cause, and then when it gets too expensive, blame that it's too expensive. So what would you say to that about how investing in earlier routine care could prevent those extreme costs later down the line?
Yeah, I guess the issue that I have is that universality is an imprecise word that means two things, right? I think what you're interested in is universal access to primary care, which is one of the cheapest things to achieve fundamentally. But I think the word universality is also advanced by industry to get very broad coverage in a very cost-insensitive way, regardless of procedures, regardless of the effectiveness of procedures and different therapies. And I think that element of universality, which people kind of bracket together, and I think the bracketing of it together is kind of unhelpful. I don't think that primary care in any way is the cost driver or the problem in American healthcare, and obviously is a very useful thing to have access to. But if it was just about primary care, then the Affordable Care Act would be a lot cheaper. The Affordable Care, the Medicaid expansion is mostly not about primary care.
Very quick.
Just very quickly that, there are ideas that have been out there for a while. 20 years ago, I wrote about should primary prevention be more of a single-payer universal system because it affects everybody and has those long-run costs. Just last week, Ziri Song and colleagues out of, I think it was in JAMA Forum, wrote a piece about should primary care be a common good and maybe carve it out, because there is something about kind of these upstream investments that if we were to try to think about that holistically, there's a whole question about where does that line draw between primary care and what comes next. But there is some, I think, really interesting thinking, including in California, where the Commission on the Future of Medi-Cal commissioned these reports, and there's a great idea that somebody wrote about having a multi-payer primary care system for California that it could do without the federal government. So there are some good ideas out there on this topic.
Hi, everybody. Thank you so much for taking the time to speak with us. My name is Karen Fisher. I'm an independent journalist. So I wanted to ask a very specific question, but I do want to begin the premise of it with the fact that in the United States, we do not have a universal healthcare system, and we often look to other cultures that do, and we kind of idolize them. But those systems are of a great cost to their taxpayers. Austria, for example, if you earn 70,000 euros, you are taxed at a 50% rate. In the United States, I believe the equivalent is something between 21 to 30% of an individual tax rate. And to be forthright, when I talk to people that are from countries such as Mexico, France, Canada, that do have universal healthcare systems, They tell me that they run for the hills to find a private provider and just pay out of pocket because they're so boggled down by waits, etc. That being said, I'm wondering if you all have any thoughts on to what degree do you hold the pay that specialists in the United States earn to account for our bloated healthcare costs? In Germany, for example, a gastroenterologist might earn $150,000 a year, but in the United States, they might earn 5 times that or more. Do you think that we overpay for specialty care, and how is that culpable in our situation right now?
So, Jeanne, you
Thanks.
do this one first. Specialist pay too high?
Yes, and I think we know that just looking at our benchmarks to OECD nations, we know we pay higher prices, but not just for our providers, across the board, for our hospitals, for our prescription drugs. So there's this debate that's been reignited again this year called, is it the price is stupid? And I think that even Mike Chernow, who criticized that, saying there's also utilization going on, I think agrees at some level it is the prices.
Chris, what do you think?
I think the issue of the cost of specialty care actually, in many European countries, the reason why they spend so much less on specialists is that there's a lot of gatekeeping of access to specialty care. And I think this almost ties into the earlier comment with what should a primary care physician do, what should a specialist do. There are 2 ways in which we, in principle, can reduce the cost of specialty care, both of which ultimately through prior authorization. One that can reduce the volume of specialty care if an insurer can determine that a primary care physician can take care of the same patient's needs. And secondly, the ability to gatekeep in that manner with prior authorization can increase their bargaining leverage, can reduce the price. So I think we've got to stop thinking about prices as sort of almost coming down from on high. The prices are created by the market leverage that various regulations give insurers to negotiate. I think prior authorization is a very important tool. It can go too far. We obviously need regulations to make sure it doesn't go too far, and that patients aren't basically kept from the care that they genuinely do need. But I think it's got a really important role in limiting needless utilization of the costlier services, especially when there are cheaper substitutes available. And I think that ties into the issue of, can individuals shop? Individuals probably don't know the price and the relative effectiveness of different substitutes. That's one thing insurers are actually pretty good at. They buy these services thousands and thousands of times every day. They know, with the progress of technology, they're able to make these determinations in increasingly sophisticated ways. This potentially is a way of generating quite substantial savings.
This is just a quick reminder to ask an unprefaced question. We don't have much time left. We started late, so let's go to 2:20 and make sure that we just ask a quick, simple, unprefaced question. Thank you.
Good reminder. Thank you. I should have done that. We'll do one over here, and then we'll do over here.
Okay. Hi, I'm Elizabeth Gardner. I'm an independent journalist, and I just have a context question for both of you. Where do you get your health insurance, and who pays for it, and how much do you use it?
Oh, that's a fun one. All right, who wants to go first?
I'm happy to go first. I get my health insurance through my job. It's a relatively small business, so it is not a sophisticated health plan. I get an account, a health reimbursement account with it, and boy, is it expensive.
I also get mine from my job. Like most workers, I think it's Aetna. And how much do I use it? I think my kids use it a lot more than I do. So thank you.
And I get mine through my wife's job at a university. So there you go. Miranda.
Hi, I'm Miranda Yaver. I'm an assistant professor at University of Pittsburgh. This question is more for Jeanne. As someone who shares the desire to expand access to healthcare and meaningful access, addressing some of the administrative burdens on which I've written. Since you brought up NFIB, I was wondering if you could say a few words about how you see the Loper-Bright decision as shaping the way that Congress might think about health insurance reform and expansion in a way that won't lose the imagination for building more progress, but also dealing with the reality that this is expansive judicial review, and we want these policies to stick?
Yeah, so that's a great question. Thank you for that. So back in the day, we were humble enough when we were drafting the Affordable Care Act to say, you know what, we can put in a list of benefits that are covered by all plans or a list of preventive services that should be covered. But we know a year, 3 years, 5 years, 10 years from now, science will change and that should change too. So we built what we thought was a learning system through regulations, through U.S. Preventive Services Task Force, through other experts, through states, through benchmarks to try to adapt the system. Clearly, that is no longer a model for durability, given the fact that a lot of that has been uprooted by the Trump administration, some in the first term, a lot in this term. People are rethinking it. It makes me sad because I don't think it's a good idea to codify everything. But I will go back to something that I'm learning from people, which is they don't trust us necessarily. If we say we're going to cover your preventive services benefits and they don't get it, they're like, you, government, are bad. I think we have to begin to codify more of this and build into the statute what people can expect from the system. Can you imagine a system where there's a list for Medicare, Medicaid, and private insurance? What is the basic benefits? There's a list of your copays, what you pay when you go to get that service. This is not me making it up. Look at Cover California. They do that for all of their plans in California. A bunch of states do that. That is what CalPERS, one of the largest, outside of federal government, public, health benefits plan does. So there are ways to do it, but I think we're going to have to adapt to this world in which there's going to be changes of administrations and people want stability. So we're going to have to begin to draft for that.
All right, we're trying to get one more in. To you.
Oh, hi, I'm Linda Marsa. I'm an independent journalist. And I sort of want to jump off with some of the other questions. 1 million Americans die every year, half of whom are under the age of 65, who would be alive if they lived in any other high-income country. That's a pretty devastating statistic, and it's been verified by several research teams. And the difference, obviously, is that they have some type of national health insurance, and we don't. Second fact, 30%.
So I want to get to the question, so.
Okay, all right. My question is, given this, what are the, because we talked about a lot of the different, here and there kinds of policy issues, but I'm looking for some type of overarching address of what are the possibilities for actually having some type of national health insurance.
Okay, quick political forecast. What are the chances of major action that will result in more people having health insurance? And we won't specify what kind. Real quick.
I agree that this country should and could be able to provide an affordable, accessible healthcare system for all of our people. We are a wealthy nation. We could do it. I think the question is, how do we get from here to there, especially in a climate when this president has not shown interest in doing it. The next president might, but what else is that president going to be facing? Oftentimes there's this question of the first 10 things. What are the first 10 things the next president will need to do? And it's a big question. Is it to fix democracy? Is it to fix the economy? Is it to actually help people suffering right now with our healthcare system? So I think the question is not whether, it's how, and I think we'll learn a lot more about that how in the coming years as we build towards it, because it's not going to happen in the next 2.5 years.
You can jump on it any way you want, or you can pass.
I think each incremental expansion of entitlements has lower returns than the previous one. When Medicare and Medicaid were created, we were basically creating an entitlement for seniors, the disabled, the low-income poor, who are out of the workforce. Very few of these groups had private insurance coverage. The more we expand entitlements, we're increasingly to catch the few people who are remaining who don't have coverage, we have to expand to groups, the majority of whom have coverage. And so the leakage rate for each public coverage expansion, the crowd out rate is getting higher and higher. It's not to say that we can't target it effectively, but it's because I think this is why we sort of slowed down in our expansion.
Diminishing returns.
Exactly.
It's diminishing returns. All right, well, that is good note. I'm sorry we would do more, but they're around later today maybe, or in IM too, and you can try to find these people. Thank you so much, everybody. This was a lot of fun. Thank you, Jeanne. Thank you, Chris.